Hello everyone, I'm Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This course presentation has to do with the United States maternity care. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational uses only. It's intended to help expand options and access, but not to substitute for clinical, professional, or legal advice. We try to keep our information as accurate as possible, but every state and local area has different regulations and needs, so expressly disclaim liability for errors and omissions. Course objectives, the students will be able to verbalize why the history of the U.S. birth culture is so different than the other developed countries. The student will be able to verbalize why the U.S. healthcare system is so expensive compared to all the other developed countries. They'll be able to verbalize why our maternal and infant mortality rates are high in the U.S., the highest compared to all other developed countries, even though we pay about 8 times more for our health care. The students will be able to verbalize why home births and midwives and community-based birthing options are not the cultural norm in the United States. They'll be able to verbalize how to help people get informed consent and decision making of the best birth options for them and their families. And we'll be able to verbalize how to educate the community and expand access to resources to change legislature, change insurance reimbursement, improve collaborations, and to better our birth outcomes in the community-based setting. So the history of birth in the United States is really interesting. Back in the colonial days, when we used to be part of Europe and we separated and we became our own independent country, a lot of the history of the midwives in Europe was just not passed along. We had a long history of granny midwives and just kind of underground filling in for villages and communities within the colonies. It never became a formal educational system or resource like in Europe. It was a long time, and even now, Netherlands has 30% of their births at home in the community center. The insurance system, the government system supports midwives in many of these European countries. Versus the United States, it wasn't started on the same framework. Physicians, hospitals really started getting into things in the late 1800s, especially in the 1920s, and made a bad image and cultural perspective of home births, midwives, and physiological birthing options. So there's a really interesting history with Dr. Friedman in the 1950s and the data and how to really get medicalized birth happening. Women were really transitioned from home, women-centered, and more physiological birth to going to hospitals where it was a teaching facility for the physicians. It was a competition. There was a lot of bad outcomes in the hospital settings with infections and just so many things that were given with the twilight sleep in the 1920s. And a lot of the medical community would entice women, and still even to this day, with pain management in the hospital, things you can't get in the home in the birth setting. It became a business. It became a revenue stream. And even still today with epidurals in the 1990s, everything is a big competition of hospitals, midwives, physicians. They have a harder time collaborating with each other. A lot of the insurance companies are owned by the healthcare systems, and you get bigger and bigger organizations that don't want the private practices. They don't want the competition. So you really have to look at the cultural trends versus, was it truly about safety? Is it for low risk healthy women? Is it really better to be delivering in the hospital setting? So we already talked about the twilight sleep, but I think a big key point was trying to ostracize midwives and get rid of the competition and show that birth is dangerous, it's not safe, you need a doctor, you need instant access to the C-sections, you need pain management because you can't handle it. There's a lot of assumptions and stereotypes and fear and propaganda put into our healthcare system, our culture, around bottle feeding versus breastfeeding, around C-sections versus vaginal deliveries, around midwives versus physicians, home birth versus hospital. There's a lot of extremes to both sides, that rarely do you see communities that they're really collaborating well and supporting each other's diversity of what they can offer. So that makes it really hard when you have a paternalistic model of maternity care, and that's still present today, where the physicians, obstetricians are mostly males and midwives are mostly females. And that mindset of the doctor knows best. We are here to take care of you. We're the experts. We know what's best. We've got all this emergency equipment here. We're going to make the best decision for you, versus a joint decision making. I mean, they just in the 1960s and 70s finally let dads back into the birth setting. You can read stories about the twilight sleep over and over again, where people are feeling, because they don't remember it, they think, oh my goodness, I had this awesome birth. They're strapped down, they're hallucinating, but they give them Versed and other medications with the twilight sleep that they just don't remember it. So we've had some pretty gruesome history of birth in the United States, and it's interesting to see the correlation in the 1970s. As soon as we started doing inductions, we started doing continuous monitoring, we started adding technology into the birth world, the C-sections and interventions started drastically increasing. The more the intervention increased, the more C-sections, the more interventions you had to do. Our population started getting sicker. We started getting a lot more obesity, hypertension, diabetes. We're getting a lot of outcomes happening with mental health disparities, and basic preventative health care is going to the wayside. And so there's trends happening where the C-section rates are slowly increasing. We're around 32 to 34%. And it's very classic with midwives, and particularly at a hospital low risk, the C-section rate is closer to 8%. So there's a definite, and the data is there over and over again to show the value for low risk healthy women of midwives and community-based setting and cost-effective healthcare resources, but it's hard to implement it. There's a lot of state regulations, there's a lot of barriers, there's a lot of restriction of trade, there's a lot of insurance reimbursement that doesn't cover out of hospital settings. They'll pay for a C-section hands down, they'll pay for anesthesia, they'll pay for all these interventions, but when it comes to high quality outcomes, a lot of insurance companies will not pay for it. It is getting better since the last couple of years with COVID and out of hospital services being needed, but we still have a long ways to go. So the healthcare cost is rising and rising astronomically in the United States, and one of the big pushes on a national and state level is cost-effective care, cost-effective care. Even the World Health Organization came out with an excellent Lancet Journal series in 2014 about midwives and the benefit and the statistics and data to show how many moms and babies we would save, and the cost of maternity care will drastically go down if we can do midwifery model of care, physiological birth, increase our breastfeeding rates, decreasing our C-section rates, decreasing the pain management, the interventions, the inductions for low-risk healthy families. So in the US, there's a lot of decision making. Our pharmaceutical companies, our health insurance companies, our healthcare system are so interconnected with each other. The hospitals don't make money off the low risk healthy deliveries. They make money when you need a lab draw, you need an intervention, you need anesthesia being charged by the minute, you need blood transfusions, you need a C-section. There are complications. There's a financial incentive to the hospitals to have interventions occur. And so it is difficult to try to help combat that capitalistic connection with the insurance companies and being paid on the quantity and interventions versus quality and preventative medicine. Some indirect costs, the premiums are rising for insurance companies, the stress, the anxiety to find great midwives, to even know in our society that midwives and out-of-hospital births exist and that it is a great option. There's a lot of barriers with health insurance companies to be able to offer this. Families can say with the Affordable Care Act, I'll go to the hospital and I'll get it covered 100% with my plan, but it's a non-covered service. If I choose a home birth, now I've got to pay cash for it, and some families can and can't pay for that. So there's a lot of difficulties that happen with their viewpoints, their experiences, their cultural preferences. If all their siblings have had an OB and C-sections and formula fed, it's hard to be the outlier. It's hard to look for different options and learn, okay, is it a safety issue? Is it a cultural preference? What are my options and choices out there for birth for me? It is amazing the studies that are out there, and I think every year it just keeps going higher and higher, and especially with the inflation we have right now. But out of pocket, it costs across the United States around $4,500 to have a baby. The home birth rate is around 4,000 to 5,000 at this point. But even if you have a baby in the hospital, most people have some sort of deductible. They have non-covered services. 1 in 3 women end up with a C-section. The baby ends up in NICU. Anesthesia, epidurals, complications after leaving the hospital. The baby doesn't get a successful start in breastfeeding, and now they have higher chances of infection and digestive issues and complications. That the cost just adds up and up and up, even if it's not directly with the birth and the labor experience, but just the complications from that overall ripple effect of not getting the best birth outcomes, the mental health disparities, the bonding, the list goes on and on of so many financial and social ramifications we have for not having more options for midwives and out of hospital births for low risk healthy families. And honestly, most of the data show 70 to 80% of the families would be great candidates for independently being cared for by a midwife or collaborating with a physician. So the average cost of a birth, even if you're in the hospital, uncomplicated, straightforward vaginal delivery, is around $15,000. The average cost when this study was done in 2018 is around $3,500 for a home birth, and then a birth center is around $5,000. I would say now in 2020, it's about $20,000-$25,000 average for just a straightforward delivery, let alone when you have a C-section, complications, induction, baby needs extra interventions. The cost just triples and quadruples quickly. Like you're going to end up with $150,000-$200,000 medical bill and out-of-pocket max met for your insurance plan pretty quickly. In the home birth, the average I would say across the country is around $5,000 for a home birth, and it's around $8,000 to $10,000 for a birth center. So inflation is definitely affecting things, but proportionately speaking, to have better outcomes, better birth experiences, it's a fraction of the cost to choose midwives in out of hospital setting. And it's the other frustrating thing is we pay 8 times more average for our healthcare. It's the most expensive in the world to get healthcare in general. It doesn't matter if it's maternity, mental health, primary care, surgery, oncology. Our healthcare cost is astronomically high in the US, and we have the worst infant and maternal mortality rates. And our maternal mortality rates in the developed countries is actually rising. We're not doing things right. We are doing the exact opposite of what we should be doing. We're trying so hard to implement physiological birth, but there's so many complex interconnected systems that make it very difficult for legislature change. When you've got insurance companies and you've got healthcare systems putting restrictions of trade on midwives and putting it so that they're non-covered services for preventative healthcare, it makes it very difficult for families to be able to financially choose these other options. So in 2018, the infant mortality rate did finally reach an all-time low in the US, 5.9 infant deaths per 1,000, but it's still more than any other developed nation. We still have a long ways to go. So in France and the UK, they have 3.8 deaths per 1,000. We have all this technology. We are excellent at saving super early babies, but we are terrible at giving good quality care. We are more about quantity and interventions and longevity of things happening than we are at what actually is happening. And so it's really, and if you talk to obstetricians in the maternal health care system, they really think we get better outcomes and don't know how bad our stats are compared to the rest of the world. And it comes clearly delineated to the more midwives are implemented into the greater healthcare system, the more improved outcomes in maternity and newborn care we have. So why are midwives not the cultural norm? We talked about the history, we talked about the changes. There's so many interconnected barriers to make midwifery successful in the United States. We have a country, so we have federal guidelines, we have 50 state guidelines, we have three main routes of education for midwives. We have certified nurse midwives, we have certified midwives, we have certified professional midwives. Some states recognize midwives, some states call them illegal, some call them illegal. Some, even if they recognize them, have supervisory requirements with physicians. Sometimes there's no birth center regulations, sometimes there's no advocacy for either not getting reimbursed from insurance companies and be able to get credentialed in network. Many midwives have barriers with insurance companies to get paid by them, to get paid fairly. To be able to run a business successfully on insurance reimbursement is very difficult for out-of-hospital midwives across the country. So there's a lot of barriers at play that we don't want to just be there for the families that can afford us. We want to be there for everyone. But until the government reforms and legislature starts enforcing that midwives can get hospital privileges, midwives can practice independently based on their scope and practice, midwives can get reimbursed, you cannot restrict them from practicing with insurance reimbursement and guidelines and standards, and that there is that respect among the greater healthcare system, it will be a difficult thing in time to change. Families are helping with it, consumers are helping with it. The out-of-hospital birth rate was around 2% before the pandemic, and it's now closer to 3.5%. So it's almost doubled, which we think is tiny, minor, but what I want to reinforce is the tiny increase has just been a hard challenge for midwives across the country. They were already plenty busy in out-of-hospital setting. We can't train midwives fast enough. We can't handle the doubling influx. So if we want to eventually get 70-80% of the population seeing midwives, we have to figure out how to support midwives with more educational resources, preceptorships, burnout, business support, so that they can handle the influx. They can't even handle the influx from going from 2 to 3.5% the last couple years. So we have to really think of it as a gentle, gradual process, and that's why I'm so personally passionate about what I do with business consulting, education. I see the value of helping midwives out with strong business structures and systems so that they can consult and support more midwives. They can have a team and a business structure. Being self-employed and being a solo midwifery practice, it's harder to make bigger impact on a larger scale than if you're doing a birth center and a team and you're really able to support more families in your community. So the healthcare burnout is getting higher and higher with midwives, with nurses, with physicians, and especially since COVID and the pandemic. I mean, there's so many midwives retiring. I talk to so many midwives about burnout and depression and anxiety and trauma. They're trying to stay afloat. And so I worry terribly about this pivotal point in midwifery history. Are we going to get through it? Is this next generation of midwives going to be able to look at things differently? They're going to have a good work-life balance. They're going to have a great collaboration with physicians and midwives and have days off and have vacations and not have their sole identity be midwifery because they choose to or not choose to. They have strong business. They have accurate fee schedules. They have strong operational systems. I see a huge impact of the success of midwifery in the future is by having more business and professional development resources available for midwives to advocate their value to politicians, to legislature, to negotiate insurance contracts, to talk to hospitals and physicians and show their value and show their business structure and be able to handle the highs and lows of whatever maternity care and birth brings their way. So there's many different birth options available in the United States. You can either have a baby by a C-section or a vaginal delivery. Some women have C-sections because of medical reasons. Some women have C-sections because of elective reasons, whether they've had a repeat C-section. It really just varies greatly by where you are located, your physician, your provider's preferences of what options would be offered to you. And it obviously depends on your medical background. If you're low risk healthy, vaginal delivery over and over again is such a better option for a birth route. If you have medical conditions, baby is breech, the baby is early, you've got preeclampsia, you've had 2-3 C-sections before, there may be medical situations where a C-section is about a better route. They're trying to push on national standards, joint, MANA, ACOG, AABC, ACNM, to try to reduce the primary cesarean section rates so that we can improve that 32% national average that's occurring. The different delivery options, you can pick hospital, birth center, home. There's different variations of birth center. There's freestanding birth centers. I've seen where there's no birth center regulations and people will have a birth house, they'll have a room in their space, they'll have an office that has extra space, they'll have freestanding birth centers, you'll have a unit that's one lower level compared to the labor and delivery unit that has access to the C-section. You could have an alternative birth room in the hospital. There's a lot of variations of the philosophy and services that are brought in each of those settings. For vaginal birth, you can have natural, you can have medicated, you can have spontaneous and induced. Natural means that you didn't get any pain medication, your body went into labor on its own, you had a vaginal delivery. Medicated means you got an epidural, you got some IV pain medicine, you had something medically done to your birth experience. Spontaneous means you went into labor on your own. Induced means that there was some medicine that was given by the hospital system to help get the labor going. So being an advocate for midwifery, it's so important that we aren't just fighting the fight by catching babies, doing our home birth, our birth center practices, and having our shop open so people can choose to see us. We need to be looking at a bigger scale of how can we advocate in our local community? How can I be a preceptor? How can I help break these barriers down? How can I meet with hospital systems, EMS, insurance companies, politicians, legislatures, insurance representatives? How can we make change on a bigger level so that we can get grants, we can start nonprofit organizations, we can start birth center franchises, we can start federally qualified health centers that will serve the underserved population? How can we get creative? And it all comes down to business knowledge. Midwives are excellent at catching babies and advocating for our family and handling emergency situations. We aren't taught about business. We aren't taught about professional development. We're not taught about how to support ourselves while we're supporting our families. And so that's where my passion and love and drive comes out to support midwifery. We need more business advocacy, professional development, and growth for the long haul of midwifery. So as an overall summary, there's so many wonderful opportunities with the United States and where we can go in the future. COVID has put a pivotal moment and opportunity of community-based healthcare, trying to keep moms and babies out of the hospital, and the COVID and infections and the staff demands that are occurring with the healthcare system. So midwives and birth centers and community-based setting are so needed. There's so much funding, there's investors. This is a prime time if you're ever considering starting a community-based private practice, a birth center in particular, that you will have no issues with a strong business plan and business knowledge to be able to get funding to create that dream practice. Our goal is to help make cost-effective, great outcomes. Healthcare costs are rising astronomically, and they're continuing to rise. We want to get C-section rates down. We want to improve our breastfeeding. We want to improve the vaginal deliveries, the birth experiences. There's so much trauma happening for healthcare providers and for consumers, and it's a ripple effect. If our Ina May had put it perfectly, your society's health is really based on how well we take care of our moms and babies. And in the US, we are the worst out of all of the developed countries in the world. Our maternal mortality rate is increasing. Our newborn mortality rate is the worst out of all the developed countries. We have to do things differently. We have to figure out a way to get midwives and community-based integrated healthcare system with midwives more. We have to figure this out. There's many different options for delivery, and depending on the mom's preferences, the birth setting, the provider, her beliefs, her medical indications of whether it'll be vaginal induced, natural at home, a C-section, some things they can control, sometimes they can't. But midwives in all settings, whether your home, hospital, birth center, can be an advocate for women and their newborns, and we need to step up and use our voices more.